Hello, this is Ann Greiner, President and CEO of the Patient-Centered Primary Care Collaborative, and I wanted to welcome you all to our webinar today, June 27th, Measuring Primary Care Investment, Overcoming Policy and Operational Challenges. I know on the East Coast you might be getting your lunch, on the West Coast you might be getting your coffee. But let me just go through a couple of quick announcements and then I will set the context and introduce our panelists for today. First, if you open up your calendars and make sure you've got on them or put on them two upcoming webinars, which I think are going to be really terrific. July 12th, we're going to host a webinar, Putting the Medical Home into Practice for Children. And we'll have speakers from the American Academy of Pediatrics, from PCC, Pediatric EHR Solutions, which is an EHR provider just for pediatric practices, and the Verdant Group, who does a lot of work with primary care pediatric practices. On July 17th, we're going to have a webinar on integrating physical and behavioral health, the view from primary care providers and payers, with speakers from Harvard Medical School and UPMC, University of Pittsburgh Medical Center Health Plan. We will also have a reactor from the UK, where they've done a good job with integrating behavioral health and primary care. So today's webinar addresses a big challenge that we have in health services research that has large implications for healthcare delivery at the state, national, and international levels. As many of you know, the PCPCC has been long committed to a strong and comprehensive primary care that keeps patients healthy and is capable of intervening early to prevent and manage chronic disease and other high-cost care. Unfortunately, our challenge is that we currently do not have a standardized way to measure what that investment in primary care looks like, so that we really can't determine what the outcome for patients is against cost of this investment, like we can with so many other medical services. Nor can we compare how one health system, an ACO, a plan, or a state invest in primary care as compared to another. So organizations or states or countries can't benchmark against each other, nor can we understand the value of that investment. And we believe that if you want to improve something, you need to measure it and you need to quantify its value. The U.S. spending on primary care is frankly dismal. It's between 5.8 and 7.7%, as best we can tell. And again, without a standardized measure, it's very hard to know what we're spending. What we do know from some studies that have been done is that there's wide variation in health plan, and if you roll it up to the state level in primary care investment. We also know that this investment is widely varied across countries, and we have some speakers that are going to address this today, and that high-performing health systems, health plans, and health systems in other countries that invest a higher percentage of their total healthcare spending in primary care get better results. So if you increase the proportion of healthcare spending in primary care, this leads to, and the research backs this up, to better population health and helps to mitigate cost increases. And it can also lead to higher patient satisfaction, fewer hospitalizations and emergency department visits, and ultimately lower mortality. So the three panelists that we have today are experts, and we're very excited to have them, who will speak about efforts to define and measure primary care, including important initiatives at the state and international level to get us to that standardized measure. We'll also have a window into an effort to generate a common primary care measurement set and a possible code set for measuring primary care spending using claims data. And finally, we'll hear from folks both in the U.S. and internationally that are working to establish a goal for investment in primary care spending at different levels. But before I introduce our panelists, I do want to put in a plug for some work that is very much related. After our annual conference on November 8th, we will be convening an invitation-only workshop with experts across the U.S. to discuss this whole issue of primary care investment and to develop a strategy and tactics related to advancing additional investment in primary care over the coming years. And apologies to one of our panelists, Jeff Markins, who really focuses on the international front, that we're only tackling the U.S. Right out of the gate. But we did really want to showcase work that's going on internationally in today's webinar. So we welcome, obviously, your participation in our conference. And if you are a thought leader on this issue and working on this issue, please alert us, because we want to have those that are most engaged in this work at this invitation-only conference on November 9th. So we want to really get the 100 or so people who are very much working to increase investment in the U.S. At that conference. So without further ado, let me introduce our three panelists today. First is Jeff Markins, and Jeff is the Deputy Director of the Primary Healthcare Performance Initiative, which is a partnership between the Bill and Melinda Gates Foundation, the World Health Organization, and the World Bank Group, in collaboration with Adrian Labs and Results. Wow, what a lineup, and very exciting to see that all of these organizations are coming together around this whole notion of performance measures and working together on performance initiatives to improve health. Dr. Markins, who's a family physician, helps to lead PHCPI's Secretariat, and in that role, he's promoting the use of data and measurement to further improvements in primary health care, particularly in low and middle income countries. Dr. Markins is also the Executive Director of Boston University's Global Health Collaborative and has over a decade of experience in grassroots primary care system strengthening, with a particular focus on workforce capacity building throughout Southeast Asia, Cambodia, Laos, and Myanmar, as well as in Southern Africa. Our second panelist, Rachel Block, is Program Officer at Milbank Memorial Fund, where she focuses on federal and state health policy issues. And Ms. Block has served in numerous executive roles in the public and private sectors, including spearheading development of New York State's Health Information Technology Strategy as Deputy Commissioner for Health Information Technology. Rachel has also was the founding director, executive director of the New York eHealth Collaborative. She's worked at CMS, where she held several senior management positions, focused on Medicaid, CHIP, and also involved in federal survey and certification programs. And finally, but certainly not last, in my view, is Robert Phillips. He's Vice President for Research and Policy at the American Board of Family Medicine. Dr. Phillips is well known throughout the health policy community as an effective leader and communicator and investigator. Under his leadership, the Robert Graham Center emerged as an authoritative source of information to guide policy, particularly as it relates to primary care, and all that means to improving the cost effectiveness of healthcare. In 2012, Dr. Phillips moved to the American Board of Family Medicine as Vice President for Research and Policy to continue to build on the research base underpinning primary care improvement, and to continue as a translator of evidence into policy. So without further ado, let me turn the baton to Jeff. And thank you again, all of you, for joining us today.
Thanks so much for inviting me to speak here today. The Primary Healthcare Performance Initiative, PHCPI, brings together country policymakers, health system managers, practitioners, advocates, and other development partners to support stronger, resilient, efficient, and equitable primary health care systems that help countries to achieve universal health coverage. Launched in 2015, the PHCPI, as Anne mentioned, is a partnership between the Bill and Melinda Gates Foundation, the World Bank Group, and the World Health Organization, together with Ariadne Labs and Results for Development as technical partners. We work together to try to catalyze improvements to primary healthcare systems in low and middle income countries through better measurement and knowledge sharing. We believe that strong primary healthcare systems drive progress on system strengthening and are the key to achieving health for all and reduced health inequities. In measurements, we aim to support countries in meeting their needs and identify an interest in strengthening primary healthcare and identifying gaps and setting priorities. We hope this then can catalyze performance improvement in a variety of areas of system strengthening. We then seek to promote cross-country learning so that countries can learn from the experiences of one another in their quest to improve healthcare. Over the majority of this millennium, countries worked on the Millennium Development Goals, and they achieved a great amount of progress on a variety of measures using vertically oriented programs. But countries have realized that they cannot achieve true health system transformation and the greater health equity that they seek by tackling one disease at a time. In 2015, countries committed to new sustainable development goal in health, which was to ensure healthy lives and promote well-being for all at all ages. I think that's so important, I'm going to repeat it again, that the world goal for health now is to ensure healthy lives and promote well-being for all at all ages. For those of you with a strong interest in comprehensive primary care, it sure sounds like primary care to me. If this is the worldwide goal, at PHCPI, we believe we need strong primary healthcare systems to achieve it. We know primary healthcare improves resiliency of health systems, increases efficiency, can meet a great deal of the need, and provides better overall and more equitable outcomes. As part of this effort, the World Health Organization, WHO, has embarked on UHC 2030, setting a global goal of universal health coverage for the year 2030. As part of this movement, there's been a broad acknowledgement that universal health coverage can only be achieved through primary health care, and that universal health coverage must include a minimum package of primary health care services. Of course, this idea isn't new. In 1978, UN member countries came together to seek health for all and declared a new commitment at that time to primary health care development. Over the last 40 years, we've made great strides in a variety of areas, as I mentioned earlier. Even further distorted health systems and failed to address important health inequities. But where there's a will, there's a way, and this October in Kazakhstan, member states plan to come together again to renew their commitment on the 40th anniversary of the Alma-Ata Conference from 1978 and bring the world's focus back to primary health care, the key to achieving the new Sustainable Development Goal for health that everyone seeks. Over the last 3 years, PHCPI has convened a variety of international experts to try to determine a framework for thinking about and measuring primary health care, and settled on 4 domains required to build a strong system: financing, capacity, performance, and equity. You'll see first and foremost is financing. And here we look to see if primary health care is prioritized in government budgets and if out-of-pocket expenses are kept in check. This is because we believe that financing underpins the rest of the primary healthcare system. It requires sufficient minimum investment to achieve success, and the system certainly shouldn't contribute to inequities by being penalizing through high out-of-pocket expenses. The second is capacity, the ability of the system to deliver effective services. We need to be sure there are trained workers, adequate facilities, and sufficient supplies of medications. The system also needs good governance and management systems with a focus on population health. The third is performance. Here we want to know if patients have access, both financial and geographic, if the quality is high, and if a comprehensive package of services is being offered. Finally, we focused on equity, looking to see if there are better population outcomes and if these outcomes are distributed equitably across the population. Now, I want to open this slide by laying out the caveat that there's a lot of uncertainty about global financing data and what the right recommendations should be, particularly in relation to primary healthcare. In considering what might be the right financing indicators for primary healthcare, we can look to a recent Save the Children report, Primary Healthcare First, from 2017. While overall, there is still scant data on appropriate financing of primary healthcare, and there's also a lack of consensus on specific targets, there are a few commonalities that we can look to. As the report states, when looking for data, figures from national health accounts often bear little practical resemblance to budget allocations, and primary healthcare allocations may not be easy to find in the budgets. In practice, budget expenditure is often much lower than allocations. As a result, this lack of transparency remains a real challenge for citizens, civil society, and practitioners that are seeking to improve the health system and hold governments to account. We do believe that, in general, primary healthcare is underfunded, often grossly underfunded. Too much is spent on vertical programs and hospital care and not enough on primary healthcare. In low and middle income countries, governments tend to cover about 17% of primary healthcare expenditures on average, and donor contributions cover roughly another 17%, leaving nearly 60% to be covered out of pocket. And that's when the Chatham House recommends no more than 10 to 20% come out of pocket on all health expenditures. If you look to the right, WHO has done some modeling to suggest that about 57% of current total health spending would need to be allocated to primary health care, compared with the median on the left of 33%, to meet the Sustainable Development Goal targets. That translates to roughly a minimum of $86 per person per year, depending on the source you look at. All OECD countries meet this minimum spend per person, but the proportion of spending on primary health care versus non-primary health care spending is typically still out of proportion. Also, little is known about primary health care spending in the private sector in general, so it's difficult to provide targets for overall primary health care spending beyond government investment. Of course, it's also important to keep in mind that even with the same spend, country performance can vary greatly on a number of other factors, which is where the rest of the PHCPI framework comes in. Using the System of Health Accounts, SHA 2011, core accounting framework, the World Health Organization is currently working to make this data publicly available, hopefully by the end of the year, for a substantial number of countries, as well as establish a common definition for primary healthcare expenditure, a basic definition that is still lacking. At PHCPI, naturally, we don't want to just stop with the data, and so in parallel, we're developing a series of improvement strategies using a variety of knowledge inputs to identify case examples from a variety of countries that policymakers and stakeholders can look to in order to then develop ways to use the data for driving improvement in health systems. So in summary, at PHCPI, we believe that health and wellness for all begins with primary health care. that universal health coverage will only be achieved through strong primary healthcare systems. We need to know and understand more about how primary healthcare is being financed around the world and the impacts of different amounts and methods of financing. We do not yet know how much financing is enough for primary healthcare. And perhaps most importantly, for a webinar on financing of primary healthcare, despite these uncertainties and data gaps, we do believe that most, if not all, countries do not spend enough on primary healthcare and need to at least rebalance the proportion of their spending, if not increase it absolutely, to place a greater priority on primary healthcare as the essential foundations for health systems. I want to thank PCPCC and all the organizers for inviting me here, and I look forward to hearing your questions at the end.
So hi everybody, this is Rachel Block from the Milbank Memorial Fund, and I'm going to speak about the work we've been doing on primary care spending measures, both the current work as well as the future work that we will be conducting in this area. I'd also like to thank PCPCC for inviting us to this webinar and for their work as well as the work of the other presenters today on these topics. Allison, I'm not moving the slides. There we go. So the mission of the Milbank Memorial Fund, as many of you I'm sure know, is to improve the health of populations by connecting leaders and decision makers with the best available evidence and experience. We mainly focus on states, but we want to make sure that our efforts are strongly aligned with those of the federal government and the private sector as well, since we believe ultimately that population health requires coordinated efforts across all of those sectors. So we start with the premise of there's growing evidence that primary care orientation does make a difference in terms of lower cost and better quality, but how will we know if we don't have measures? Next slide, please. So one of the questions is this something that we can actually influence with policy? And many of you know Chris Kohler, our president, had a previous life as the Health Insurance Commissioner of Rhode Island and spearheaded their efforts to prioritize primary care investment. And in these couple of slides, what you will see is the results of the increased spending on primary care as a result of specific regulatory requirements that were established by Rhode Island. And you can see clearly that those regulatory requirements made a difference in terms of how much was being spent. If you go to the next slide, not only how much was being spent, but what it was being spent on. And we like to focus on both of those things because it's not just the amount of dollars, but also how those dollars are being dedicated to the infrastructure for improved care management in primary care settings. Next slide. You click through all of those, it's an animation. So the other thing it's important to recognize is that while the state's health insurance policies made a difference, there were a lot of other things going on at the same time. And as I mentioned, we think it's very important to focus on alignment. And you can see that this combination of additional activities, a primary care-based ACO, a health information exchange, a strong PCMH program from Blue Cross, and a multi-payer primary care transformation collaborative, we're all really reinforcing the additional spending on primary care in terms of its impact. Next slide. So what is the fund doing to build on that experience? We're building evidence through research support. We're disseminating and using that evidence through reports and through convenings of state and other leaders. And a few examples of the areas that we focused on, which are not limited to primary care spending. One of our signature initiatives is the multi-state collaborative, where we have brought together the CPC Plus project sites, along with CMS and the various support contractors who are working on that initiative. We've published several reports building on the evidence of primary care and behavioral health integration. We have supported PCPCC in their annual reports for the last couple of years, and most recently, the work that we're doing on primary care spending measures. Next slide. So along those lines, last year we published a report, and the link to that report is included on this slide. You see the cover of the report. We contracted with Bailiff Health Purchasing, which also had a subcontract with the RAND Corporation, to do this work. Next slide. The purpose of this study was to undertake a proof of concept to determine what percentage of total medical spending high-performing commercial health plans spend on primary care. We focused on high-performing plans because we thought that it was likely that they were the ones who would be spending the most on primary care. So to a certain extent, we were priming the pump, so to speak, in terms of what we would expect in terms of the results of the data analysis. Next slide. The way that this study approached defining primary care, there are measures that are broken down by different primary care specialty categories, by different service codes, by age groups under age 65, and also by two product lines, HMO and PPO, for those health plans. And in a nutshell, what we found in that proof of concept study is that there wasn't as much difference when we looked at different combinations of primary care specialties, but there was more difference when you had either a narrower or a broader definition of the service codes that were included. Essentially, at the narrow end, those things which are very strictly traditional primary care services. At the broader end, basically any services that are provided by the specialties in those service codes. Somewhat predictably, more spending for children and less for older adults. And we also found in that particular study, there wasn't a whole lot of difference between the HMO and PPO product lines in terms of their spending amounts. Next slide, please. But having said that, there was significant variation among the plans in terms of what they were spending. And I'm not going to go into the detail of the numbers here, but if you simply look at the range, this is dollars, the A, PCPA, narrow definition of specialty, PCPD, the broader definition, also A, narrower definition of service codes, D, the broadest definition of service codes. What you can see is that the amounts, as I said a moment ago, between HMO, PPO didn't vary a whole lot, but in the parentheses, you'll see the range among the different plans that were participating in this study. Next slide. And here we show you the percents. And again, in the parentheses, you see that there is a significant variation among the plans that participated in this study. As you see, anywhere, for example, in that lower right-hand quadrant, from 3.4% to 12.5%. Next slide, please. So what are some of the broad messages that we brought into and take away from this initial effort? First, we believe it's important to measure primary care investment. This proof of concept study shows that it's feasible to develop and use primary care spending measures. We see there is variation among payers, but we don't know enough yet to explain why. So we need broader use of the measures to help illuminate that. Measurement resources are required, and you need to plan for it. And our study certainly showed there were significant resources on the insurer side. In our case, as the sponsor of the study, obviously we had to provide funding for the data analysis. And if you are a state, there would similarly be costs associated with doing this kind of work. And also, not so much directly related to that first study, but as we go to more emphasis on the publishing of this data, it's important to have a process that is transparent and data that is trusted. Next slide. So the fund is continuing its work in this area, in part by collaborating with primary care specialty societies and researchers to continue to drill down on the refinement of the primary care definitions that are being used. We're also sponsoring additional research using similar measures to establish fee-for-service spending levels for the Medicare population. And along those lines, we will be publishing 2 studies. One will present overall information on fee-for-service spending levels. The second will focus on spending levels at the physician group level. Unlike the commercial study, however, we will not be able to look at non-fee-for-service payments amounts because we are only using fee-for-service data. And this is an important distinction because many of the investments that are being made in primary care infrastructure are being done outside of fee-for-service claims. So there will be that one big caveat in terms of the results, but nevertheless, we will have some better idea of claims level spending for that population. We're also working to connect with other national organizations that are developing and using various kinds of healthcare spending measures. For example, the Healthcare Cost Institute last year published its update on healthcare spending. It included an initial analysis of primary care spending measures, and we're currently working with them to utilize the measures that were developed under our proof of concept study. Next slide. In terms of additional next steps, we're working closely with states to replicate the use of those primary care spending measures and also to monitor their work on additional legislation and regulation. For example, the New England States Consortium is a group which communicates regularly on various health policy issues across the region, and several of those states are now collaborating, and we anticipate that they are going to produce a common primary care spending data report for 4 of the participating states that have sufficient data to do this. In addition, you'll see at the end of this presentation, there is a list with some links to current and proposed state legislation. We're also working to disseminate these results at professional meetings, and this is also where our partnership with PCPCC is very important. And finally, we will continue our work to support multi-payer models that support stronger primary care investment. Next slide. So if you have any questions, I have both my contact information. My focus is on primary care spending measure development, as well as broader efforts by states to use total cost of care measures. Also, Lisa Dulski-Watkins, who many of you I'm sure know, who directs our activities for the Multi-State Collaborative, and you should contact her if you're interested in that work as well. And the last slides are simply links to additional references that we've used to explain our work and also to share with our state colleagues and with other stakeholders who are interested in this topic. So thank you.
This is Bob Phillips with the American Board of Family Medicine. I'm also very grateful to be a part of this this panel presentation, and I've already learned a lot from Jeff and Rachel about work that we've been talking about together. But the depth here is very, very helpful. I want to talk about work that the American Board of Family Medicine has done with the Robert Graham Center in particular, looking at the context of primary care in the United States and this approach to measuring investments in primary care. Starting with context, if folks aren't familiar with Carl White's Ecology of Medical Care Boxes from 1961, it really demonstrates that if you look at 1,000 people in the United States, in the community, that about 800 will tell you that they've had some illness or injury that for which they've considered seeking care. About 250 will actually get primary health care. About 8 wind up in a hospital, and less than 1 wind up in a university or academic health center. So that was true in 1961. The Robert Graham Center reproduced this in 2001 and showed that it had not changed at all in 40 years. And then Johansson and their group in 2016 published in New England Journal another comparison looking at the same data for 1996 versus 2012. So the x-axis here is 1996, the y-axis, or the vertical axis, is 2012. And if the data are equivalent, if they're the same across those 2 different years, then you should see them line up along that equivalent line in the middle. And in fact, they do. There's very little variation along that line, and that was highly interesting considering that we had just gone through the Affordable Care Act and access to insurance was expanding. The inset graph is a blow-up of that lower left corner looking at hospital, home health, and other therapies, and really showing that 8 out of 1,000 inpatient hospitalization rate is still the same as it was in 1961. So primary health care and people seeking of care, the patterns of care-seeking behavior have really not changed in 50, almost 60 years now. And out of 1 billion visits into the outpatient setting in 2015, and another 141 million visits to emergency departments, 51% of those visits were in primary health care. So it's a large volume of care, particularly for people who may not touch any other part of the healthcare system. So looking at investments and how this enterprise is funded is fairly important. So if you look at primary health care and evidence that have been produced, at least in the United States, I'm sorry, the slides are acting up. My fam, who while she was at the Innovation Center at CMS, at a AAMC meeting, pronounced that it was 3.6% of total healthcare spend under Medicare. And the Health Affairs article that came out this month looking at CPC Plus with Debbie Pikus from Mathematica as the primary author, and the discussion section, she reveals that in the CPC Plus community, it's 5% of total spend. And Rachel presented the information from Milbank and their work with RAND that was published in New England Journal, showing that in the commercial market, it's somewhere between 4.8 and 7.6% of total healthcare spend. And the Organization for Economic Cooperation and Development with the Gates Foundation and World Bank in 2016 produced their initial report on primary healthcare spend around the world, showing that in developed countries it's about 12 to 17%. The United States did not provide sufficient information to be included in that analysis. So seeing this variation, we actually got together a group that I'll talk about in a minute in December to try and see if we couldn't come to some consensus about a definition. Because as Jeff alluded to in his conversation, and Rachel as well, if you look across efforts in the United States at least, the Rhode Island effort to mandate primary care spend threshold, which moved total healthcare spending from 5.4 to 10% between 2007 and 2013. In their 2014 evaluation report, if you look at the numbers, there was an 18% reduction in total healthcare spending. Because of the differences in how much of total spending is in each of those buckets, it was about a 7-fold return on investment. And as she said, there's a lot of things happening in that same space that could help explain this, but that's a pretty robust change in total healthcare spending. The Commonwealth Fund a few years ago also published a report showing that the 10% primary care incentive payment that came out of the Affordable Care Act was associated with a 6-fold return on total spending reduction as well. And the Robert Graham Center's evaluation of the Illinois Medicaid effort from 2006 to 2011, we were able to demonstrate a 31% increase in Medicaid primary care spend was associated with a 33% reduction in total spend, which saved about $1.5 billion over a 4-year period. So there are some real associations here. I'm not trying to imply that they're all causative, but these are not small changes that are associated. The Graham Center, working with the American Board of Family Medicine, have used the Medical Expenditure Panel Survey, one of the U.S.'s national healthcare surveys, to look at spending by sector. And using that data set, we reproduce this 6% total healthcare spend on primary care. And that's compared to a 27% spend on inpatient care, a 26%, or actually 25% spend on prescription drugs, which actually turns out to be the category where spending has increased the most. So there's a consistent pattern of what this total healthcare spend contribution to primary care is in the United States, and no matter how you look at it, it's significantly lower than what other countries are spending. Now, this interest in differences in methods is important, because looking at that same MEPS analysis, if you look at it using the Rhode Island definition, if you look at it using the Oregon definition, because they've also implemented a minimum primary care spend threshold, or if you look at it using the OECD definition that the World Bank and Gates Foundation have put out, you see quite a difference in the estimation. So in our analysis, the Graham Center's analysis of the MEPS data showing an average of about 6%. If you use the Rhode Island definition, it rises to about 8.4. If you use the Oregon definition, it rises to 11. And the OECD definition, it rises to between 13 and 14%. We put also that last column, the reported percent spend from the various studies. We use that as a comparison to see if our estimate from MEPS was comparable, and it was. So it really highlights that the definition you use for what goes in the primary care bucket when you're considering or looking at costs is quite important. So leading up to our December definition effort, which was sponsored by the American Academy of Family Physicians, the Robert Graham Center, and the American Board of Family Medicine, we brought together a number of key stakeholders from around the world to do a key informant interviews beforehand to try and prime that conversation and get at people's ideas of what should be in that primary care bucket. And so we had a very good set of contributors to thinking about this, and people who are doing some of the analyses across countries now. And as Jeff alluded to it very early on, there is growing understanding that improving health in poorer countries, not just healthcare, but improving health as enricher, is the provision of comprehensive primary care. That was a statement that Sir Michael Marmot made in Lancet in 2006. He's one of the fathers of understanding health equity and the impact of social determinants. We also recognize that there are some differences in definitions about what is primary health care versus primary care, but there's quite a bit of alignment. There's important differences, but quite a bit of alignment, whether you're talking about the World Health Organization or what's now the National Academy of Medicine, Barbara Starfield's definitions, or the European Union's population health definitions. But there's a mixture in here of who's doing the work, where they're doing it, and what is actually being provided. In the United States, we tend to lean very hard on first contact, continuous care, comprehensive, with a high degree of care coordination that Barbara Starfield had and her studies showed was so valuable. But there is quite a mixture of how do you look at it in these definitions. So in talking to people before we gathered in December, we got some of the same responses. So, frontline, first touch, first line lines up a lot with Barbara Starfield's 4 C's. Comprehensiveness comes out in terms of thinking about taking care of the majority of problems. This idea of team care really came out quite a bit, that it's not a person, but maybe a set of people who are doing it. And that also this mixture again of services versus setting came up quite a bit in trying to frame the idea of comprehensive care. And then continuity, even if teams are delivering care, there need to be particular people in the team who have that patient's long-term caring relationship at the heart of their accountability. In terms of challenges, there was recognition from the start that we may not be able to come up with a single definition of what belongs in the primary care bucket. And that's a challenge because we have different data across countries. We have different people actually providing the care. And what we should really be working towards is some way of accomplishing meaningful comparison when you're looking across countries. There was also agreement that at least within the United States, we probably should work toward not just meaningful comparisons, but some standardization so that the work that Rachel talked about that's happening across states and trying to develop policies to support more robust primary care, we probably do need more standardization. And again, in terms of the purpose of the definition and the methods, it's really for an international purpose. It's about trying to create some way of supporting comparison, but that we need to be more specific when we're talking about advocacy efforts around primary care spend. And Alice and I just lost our presentation, but I had a couple more of the key informant ideas, but I think you're probably getting the gist of it. And where we came down to was this idea of that we're probably looking ideally at this overlap. Oh, good, thank you. We're probably looking at, as Rachel gets that next, I've lost control of the slide, so Rachel, if you could advance to where we were in terms of the next slide. And the next one. Right, thank you. So there is some overlap of workforce and setting and services. And so we wound up with this target model that for comparison purposes, the best that we can probably expect is this outer ring where we're looking at primary healthcare services. So particular services that primary healthcare should be delivering and what's spent on those. Now, just by way of example of why this might inflate your estimates of total healthcare costs, if a general internist does a stress exercise stress test for a patient, that could fall into primary healthcare as a comprehensive function. But if a cardiologist does it, it would not. But if you're just looking at services, you would capture both of those in this outer ring. If you can move into the next ring, then you're looking at services and who's providing them. So if it's a primary care clinician that's providing those services, then you can start to eliminate some of the costs that shouldn't be in the bucket. But you still might be capturing costs that aren't what they should be. So if you have a family physician seeing their patient in the emergency room or seeing them in the hospital, you might want to capture those in the cost bucket because those are examples of comprehensive care. But if you have a family physician who's only working as a hospitalist or working in the emergency department, then having that primary care provider do that service is not in the same context because you're particularly losing the ideas of care coordination and continuity. So the ideal definition that folks said we should continually work towards is that combination of primary healthcare services being delivered by a primary care clinician in the context of meeting that fuller definition of primary care, that there's first contact, there's continuity, there's comprehensiveness and care coordination. And we know that's a very high bar to get to in terms of setting up our data to make those measurements, but understanding that's what we probably need to work towards. If working across countries for comparison purposes, we can only get to the outer rings, and that may be sufficient for us to help understand outcome differences based on spending, but it probably isn't enough for us as an advocacy goal within the United States. So I know we want to make sure we leave a little time for discussion, so I will stop there and join my colleagues in responding to your queries. Thank you.
Thank you so much, Bob, and also thanks to both Jeff and Rachel. This is Ann Greiner, and that was a fabulous set of presentations. And thank you all for staying with us when we had a little bit of a technical glitch. Allison, thanks for your recovery as your computer crashed. So we do have a couple of minutes for questions. Please write them into the chat box. We got a number of questions in advance, which was wonderful. So let me start off with those. One of the first questions, and I think I also want to just focus on Bob's slide where he showed why it's so important to have a standardized definition, and our focus is going to be, on the U.S. As an organization, but why it's so important when you looked at how the different definitions gave you very different results. If you're talking about Oregon, which has implemented legislation to move to 12% of spend on primary care versus Rhode Island that has had that legislation in place and went through that increase over a 5-year period versus the OECD definition. So I think that slide really does reinforce this notion of why it's so important. One of the first questions we got was, whether or not it makes sense to include pharmaceutical spending in the primary care calculation, and Oregon has not. I've talked to health plans that have, and I don't know if any folks on the phone want to tackle that question, because clearly that's a very big expenditure. Maybe you want to take that, Rachel, since you've looked so deeply at the U.S. piece.
Well, I'd love to have Mark Friedberg, who was the author of that analysis and will be doing the additional research that I described, to answer that in greater detail. But I'll just say, for purposes of the initial study, the pharmaceutical spend is included in the denominator, but it was not included in the primary care spending component. Gotcha. So in other words, we counted pharmacy as part of total cost, but not as part of primary care cost.
Sure. Others on the phone want to comment on that? Whether or not it makes sense or does not. Clearly, the primary care clinician, has great influence over pharmaceutical spend.
This is
so Anna.
Sorry, Bob. You can go ahead.
No, please go ahead, Jeff.
I was just going to say conceptually that it does seem, at least from an international perspective, I think, important to consider including medications in that primary care spend. We look at primary health care versus primary care, as Bob was talking about, and trying to distinguish that definition. There's a bunch of different elements of primary health care that we try and deal with improving in low middle income countries, but probably the two most closely associated with primary care are basic treatment services and essential medicines. And it seems to me that it would be difficult on the international stage to separate those, and so much of one depends on the other.
Yeah, and I would agree, because that's not spending that is contributing to the primary care functions. It's certainly contributing to the patient's care, but not to the primary care functions that we're trying to enhance. Those are costs that are out of primary care's control. In fact, as I showed, they're the fastest growing sector of costs, and they're the largest sector of costs. So they swamp the other expenditures in primary care and don't help you in understanding how investments in primary care capacity lead to better outcomes, because the number is just so overwhelmed by the prescription costs. And the last thing I'd say is while primary care does certainly direct a lot of the medications that people take, accounting for who prescribes those medications can be quite difficult. So if a psychiatrist puts a patient of mine on medication, I often wind up managing the future prescribing of that medication. And same thing for medications prescribed in endocrinology or cardiology, is I often become the manager of those, even though I didn't decide that those were the medications that I would have chosen. For good or bad effect, often those are the right medications they should be on. But I didn't initiate it, and I wasn't the instigator. So attributing those costs to me is probably not right, and so it's difficult across all medications being prescribed to give proper attribution.
Thank you so much. I know when I looked at the report that Bob led, there was an acknowledgement that low, middle, and high income countries may have different approaches, but also needs when it comes to primary care spending. So just keeping that in mind. And we saw Jeff's results where developing countries are already spending much more than, for example, the U.S. spends on primary care. So this is really a question, I think, related to the U.S. Sorry, Jeff. For those at the state level who, and we got a question from the state of Rhode Island that has introduced legislation and is interested in understanding what is the right number, Delaware, what is the right number to, advocate for? Is there an evidence base, or what is the optimal number for primary care spend? What do we know from the evidence? What would you advise folks at the state level?
Do we get to have Bob answer that?
I was going to say a little silence there.
Oh, Rachel, I would say that the evidence is still out. There's not a good empirical evidence-based number. When a paper we published in 2010, we showed that we did have some empiric relationship, and we had proposed a 50% increase in primary care spend at that point through federal payers based on that evidence. In another paper in 2008, reflecting on in Health Affairs, reflecting on the comparisons around the world, we said perhaps 10 to 12% is probably in the right range. So a near doubling of what we spend in the United States. Overall, even though we don't have something empiric to fall on, what we're still talking about is less than $1 in $10 spent on healthcare, probably. So the investment change is not a huge shift, and if the value that's been returned is reproducible compared to what Rhode Island's seen, what Illinois saw, the net cost will be, if not negative, comparable.
Well, thank you so much to our presenters today, Jeff, Rachel, and Bob. We really appreciated all that you were able to convey in the short hour that we had together. We at the PCPCC are going to continue to work on this issue, so please visit our website to see material, op-eds, and our continued policy work, as well as our upcoming conference and workshop will address this issue. I want to thank everyone for joining this afternoon, and we look forward to continued work on this very important issue. Bye now.